everybody. So I'm going to talk about a project that we did together with the National Center for Medical Advice Giving in Sweden, an organization called 1177. So I'll give you some background on that in just a minute. So what we've been looking at are the potential benefits of using telephone and web in an integrated manner, using dynamic markings as a complementary to telephone-based advice giving. So first, a bit of background about the system in Sweden. So 1177 is a national telephone service, and it's open to all members of the public, 24/7 access, and free of cost. It's manned by registered nurses, so people can call in and get medical advice giving over the telephone. They also provide kind of a guidance function for the Swedish healthcare system to help you navigate the Swedish healthcare system. So this is intended as kind of convenient and cost-efficient way to provide a kind of first line of defense for the Swedish primary healthcare system, and it's pretty efficient in that also. And the same organization curates a big knowledge base with easier to understand information about common diseases and conditions. And that's available through their companion website, 1177.se. And all really high quality information and worded in a way so it's accessible for the non-medical professional. The basic idea in the project I'm presenting here today is to see how we can use these two channels of communication, the telephone and the web, and use them together in a more integrated manner. And in this, hoping to provide a more kind of high quality, high expressiveness type of advice giving over distance. And also seeing if you can extend the range of issues that can be managed or handled over distance. So we built a prototype system and tried it out together with the 1177 personnel, and have run a couple of controlled studies using eye tracking methodology to try to get a deeper understanding of how telephone and web, verbal and visual, work together to provide kind of an advice-giving, counseling service for the members of the public. So the tool put together allows an advisor to connect a web session to an ongoing telephone conversation. So you always start with the telephone conversation, and then if it's found to be necessary for that kind of extra level of expressiveness for some reason, then you can add on the web session. So it's added on by having the user go to a specific web page, click a link, and then that connects their browser to the browser of the advice giver. So once the session is established, it's kind of a simple co-browsing system. So that means that links are synchronized, so page changes are synchronized. So if either party clicks a link, it changes its page for both parties. So it's a fully cloud-based, no installation, no configuration, just a generic browser and easy to get going as this kind of add-on to the telephone conversation to be used if necessary. So we synchronize the page changes. We don't synchronize the scrolling or anything else in this. So we have kind of the using a deliberately weak type of synchronization. So giving each party kind of the freedom to explore the current page from their own perspective. So that's kind of a deliberate design philosophy to use as little synchronization as possible, because we want to leave some measure of freedom, especially for the patient, but also for the advisor in that situation. Then we have the marking functionality. So this allows the advisor, and this is only available for the advisor, this functionality, to create dynamic markings on the page that is currently activated. And these immediately show up then on the side of the patient. And this can be used then to dynamically control attention, bring focus to a certain area on the web page to kind of underscore the argument, to give extra information, or something like that. it can also use to shift information to a new area on the page. So by shifting from one marking, highlighting that marking, then shifting to another, we can dynamically control the attention. So it's kind of a pedagogical over distance aid for the advisor to show, to control the kind of the sequence in the conversation. Right, so the two experiments we've done with eye tracking, so I won't go into the details of what we've done here, but if anybody's interested more in eye tracking research methodology, come and see me, I can give you some hints there. But we did two different studies to kind of analyze what people actually look for and how the visual behavior they present interacts with the verbal behavior. And what we were especially interested in was how the dynamic highlighting that we use to drive focus as the conversation progresses, and two types of attentional control: selection guidance and dynamic guidance. So selection guidance concerns the ability to kind of influence what the patient looks at and what they don't look at on a page of the total time spent on a visit. So that's the selection bias. The dynamic control is controlling what the patient looks at right now. So that's kind of deciding the tempo of the conversation. Right, so here we see some of the results from that study, and this is about the selection guidance. And this is a heat map generated by the eye tracking analysis software. So this shows an aggregated viewing behavior. So this is a number of participants showing what it looks like when they're looking at this page while receiving guidance in these controlled experiments. So the heat map works like, you know, if you imagine your eyes shooting lasers, that's burning holes in the page, right? So again, aggregated behavior. So this is a number, I think about 10 patients. So the areas of high intensity, shown in red, they get the most attention. So here we've got a very clear picture of the way that the visual guidance drives the attention on the page in a selection way. So using just selection markers, we can help the user to focus in on certain areas and ignore other areas for the purpose of the ongoing advice giving. Of course, verbal content, the telephone bit of this, that also drives attentional focus. So we did a couple of different conditions to check out what kind of influence the verbal guidance has in comparison with the visual guidance. So they complement each other and the patterns are similar, but we have a much more pronounced and clear pattern when we use verbal and visual guidance at the same time. So this is for the kind of selection guidance or selection bias. This is another view of the same data, which gives more kind of a direct view of what they're actually looking at. So it's same aggregated viewing behavior, and here we see very clearly that it's the marked out sections that get the most focus and attention. So the next thing was the dynamic guidance, how we can use the markings to intentionally drive focus between different areas. So this first slide shows the progression of going through different focus areas on this page. So it might be a bit difficult to see on this screen, but you see the little red markers? That shows that we have one section being highlighted in each of these sections. So looking again at the heat map results of this, we can see we have a very strong guidance of attention where they're focusing on each of these areas in that progression as the advisor is highlighting each of these areas. So again, we have the verbal and the visual together. So again, we had separate conditions to kind of try to extract the influence of the verbal guidance we had in this. And again, the pattern was similar, but we got much stronger focus when we used the verbal guidance and the visual guidance at the same time. There's also a point of the actual dynamics of guiding that control. So we looked at time to target numbers. So when you actually change from one target to the other, we also have much shorter switching times between focus areas. So again, that's a measure of our ability then to guide the attentional control as a sequence in concert with the verbal information that's given. So again, another view, this gives an even clearer picture of the level of attentional control that we can achieve with this double visual and verbal guidance. And we see we have a very clear control of progression. And again, this is an aggregate over a number of subjects, so we have a very clear control for all of those. Because the averages kind of hide the individual in this, we also looked at the individual analysis of the eye tracking patterns that each individual participant had. And this is for analyzing the type of behavior patterns that we have when we follow the path of using this. So the aggregates we had before, they tell us something about the ability to control attention, both selection-wise and dynamically. But following the kind of story of each individual user tells us something about the dynamics of how they actually progress through a session like this. And this shows us that there are different kind of search strategies that different people use, different kinds of individual inclinations on how likely they are to stay on target. But we can also see that the kind of quick forays that they do into other parts of the content can be very positive. It could be that they're looking at the context area and getting hints for other questions to ask in this related area and stuff like that. So looking at the individual parts, we can also identify the positive behaviors that we might not see then in the aggregated behaviors, where we're kind of trying to get them to control the attention as much as possible. The qualitative analysis also revealed that there were lots of commonalities, but also individual differences. So that gives us hints how this type of advice giving can be customized to the individual preferences, to the specifics of the material covered, and lots of other types of factors. And we don't get that in the aggregated analysis. So what we learned here is that complementing verbal instructions in this way with the visual guidance part, it does increase attentional control. We believe that should translate into increased precision and exactness in knowledge transfer. However, the pedagogical value doesn't naturally flow from this. It's not negative in a sense that somebody doesn't stay on focus the way the advice giver wants them to stay on focus. Like I mentioned before, if they have a positive viewing pattern, looking at other information, that can definitely be positive. So in coming research, we're going to look at more how the pedagogical value is affected by different individual viewing behaviors and different praxis in also using the kind of attentional control mechanisms that we afford these advice givers. And the goal, the ultimate goal then, of course, is to have some kind of effect on outcome. And the outcome, that can be learning, retention, motivation, also a complex picture. So for advice giving, the final outcome will be if it helps them to manage their health better in some way. But that's a kind of long-time goal and more difficult to quantify. But what we're hoping to go into and see the kind of final effects of how this type of functionality can be used. Using web as kind of complementary asset has also additional benefits. Having the web page there gives patients visual records so they can go back to that. So even after the session has finished, the visual markings are gone. They have something to kind of a hook to go back to and reiterate the information, read more, look at other sources. So that's a positive benefit of using the web as a complementary resource. So the attentional driving forces is during the actual advice-giving session, but using the web as a complementary asset lets them use that as an additional learning asset also after the session is finished. It can also provide context, hints, background, and stuff like that. Some of the success factors, because we tried quite a lot of different versions of this system, and ease of use was actually absolutely critical on both sides, and making it as easy to use. So both on the presenting side, the way these visual guidance markings were presented to the patient, and also on the advice giver side, the way they actually created these markings. But generally it was, the easier the better for both sides of this. The when to use and when not to use was very critical also, that this wouldn't be a service used as a hang-on to any telephone conversation. So choosing when it's appropriate to use this would be an important part of the praxis of a service like this. So finally, the next step, we've done so far only kind of controlled experimental studies, especially looking at the kind of ability to drive attention control within this. But the next step is to move ahead and try it out on real patients. So we've used the local chapter of the 1177 organization, and they're ready to kind of go ahead and try it with real patients. So still some scaling up issues and also some legal issues. And we've got a commercial partner to help us with those aspects on that. Finally, what I've talked about here is how 11.7 can use their telephone service, existing telephone service, and their web resources as they are. But where I see the real promise for this type of service, not specifically this implementation of it, but the type of service, is to allow a service like this to qualify resources on the web. So the technology behind this is not limited to the 1177 website, but any page can be used for this. So by introducing kind of the professional voice on the web in a very simple, low threshold, low entry threshold way, professional advice givers can go onto the net and help people answer questions with the wealth of material that's out there. So that's what I see like the bigger picture and the bigger goal within this. But we're starting small, looking at how 11.7 can use their own resources to start with. Right, thank you.
Great, thank you very much, Martin. Does anyone have any questions? We have about 5 minutes for any questions that the audience may have. Sure.
It sounds. Thank you. So it sounds like you haven't done the outcomes data yet to see if this affected. But did you get any preliminary feedback, even anecdotal, whether people enjoyed using it? Did it help them concentrate?
Yes. So within the study, everybody was really positive. But there's always kind of positive bias in that kind of study. But I thought the takeaway from it was the advice giver side, because these are advice givers who work on this every day, and seeing how they saw that they could use this, and in what proportion of cases that they have that they found it useful, and also the types of situations, to increase expressiveness, to increase trust in given information and stuff like that. So that was really interesting, and they could definitely see them using that in practice. And also that they kind of very open to start using it. And it's a simple system to start using it. It took them about 10 minutes, and then they're ready to actually use it in practice. But I think that was mostly the takeaway from the advice giver's perspective, because they had that body of experience to build on.
Any other questions? So. Sure. Yeah.
I know this wasn't one of your study parameters. Was there any impact on the amount of time required to convey the information that they typically want to convey in that session? Because right now they're just doing it verbally, whereas with this model they actually have a chance to also use visual data to convey that same information. Was there any other feedback or assumptions that we should take into account?
Yeah, we looked at time, and I've done a couple of other studies, similar setup, and looked at time issues. And in general, it's not more efficient when it comes to time-wise, but increases the quality, and it also kind of makes it possible to deal with more difficult questions, and especially when you need that kind of preciseness and exactness of knowledge transfer. So if it's a question of exact dosages, and if you get it wrong, it can be really serious. Today they kind of, if they get those kind of questions, they always refer to primary care, because it's too dangerous if they get it wrong just using verbal instructions. So, remains to see if they would use it for that. But again, the advice giver said that that would be a situation where they could see that it would be really useful, because then they could have much more precise indication and confirmation that they've seen the right thing. And we're kind of looking at feedback mechanisms also, where the patient can actually click parts and show that they've looked at the right text. So those kind of confirmation stuff and exactness, precision, increasing in effectiveness, but probably not efficiency. Right, so I'll repeat the question. Timing-wise, if it took longer in the different sessions, not typically. So it was, it's kind of small study where I compared the times, but definitely no significant difference there. Maybe slightly longer with the web material because you had a little setup stage. So probably the longer the session, the less you work, you get that time back. But pretty much spot on, the same kind of time differences. But I'm pretty sure if we tried it with more different situations, with more complex questions, different types of questions, we'll have more time variation.
Great.